Hello. Hi, Brent.
Morning, Simon. Morning, Rachel.
Hello, how are you?
Really looking forward to this. Congratulations.
Yeah, well, so let's hope somebody turns up, eh? I mean,
I've invited some people.
Look, I've had to have a haircut. I've got my tie on, look.
Very good.
And here's Triggy coming, I think. Triggy, hello, Triggy.
Hello.
Hi, Triggy. How are you?
Good. How are you?
Well, I'm okay, thank you. This is the first time we've ever done a conference like this, so I'm pleased to say Rachel's got a lot to do, a lot of work to do.
She's got it covered.
So, yeah, well, she's a professional. I just try. But we've had a few practices and things. So, Triggy, where do you live?
I live in Arlington, Virginia, outside Washington, D.C.
Okay, and what's the weather like?
Kind of gloomy, actually.
Is it nice weather?
Yeah, it should be nice and spring-like, but it's been very overcast and
Triggy, you've
cool.
sent me an email. You've asked, is the meeting being recorded? And the answer is yes.
Awesome.
Okay, we didn't used to record them, but now that we've updated the website a little bit, people seem to like to be able to, well, Brent actually, Brent likes to be able to have a look at it and look at what was said, because Triggy, I haven't even got a clue what people are on about, so I just sort of go along with it. Brent has some idea, and Rachel has a PhD in NETS, and she has no idea. None at all. She doesn't know what they're talking about. So, Triggy, I hope you enjoy it. We never know how many people are coming.
Are you able? I think the speakers will share their screens, right?
Yes.
So
Yes.
Maybe you'll have to enable that.
Yes.
Just a random thought I had.
And I've been practicing and all sorts. Do you want me to tell you what I'm going to say?
Sure.
Just do my usual. Hi, my name is Simon Robinson, and then smile a bit and get somebody's name wrong. That's always amuses people. Particularly Poe's name. Brent's laughing.
Say her name. Poe Hien Ear.
Yeah. Hien, I call her Hien.
Is that correct?
I don't know.
What about, how do you say Gayle's last name?
Morell.
Morell. Okay, that's what I thought.
M-O-R-E-double.
Morell.
Morell. And here's Catherine, and Catherine is one of Poe's gang.
Yes, hello. I work in Dr. Ear's lab.
There you go. See, I'm learning something.
Catherine, can you pronounce her full name for me real quick?
Sure, Catherine Tran.
Oh, what about Poe's full name?
Oh, Hien Ear.
Okay, thank you.
Yeah, I know it's not easy to read.
I'm gonna make sure I say it right when I introduce her.
Which is it? Hien or Hien? Hien. Oh wow! So I've said it wrong every time.
Simon, if Rachel's going to be your co-pilot, you may want to make her co-host so that she can do some of the Zoom properties if the speakers need it.
Well, what we've got planned is quite straightforward. It's just I wasn't going to be here, was I? Because I was going to be in hospital. So all I'm going to do is just say what neck cancer is, and then we alternate between Rachel and Kate.
Okay, you've already got some co-hosts. Good,
yeah,
good.
Yeah. So all we're going to do is Kate or Rachel are going to introduce the speaker. So I'm hoping that they've done a little bit of research on them. Otherwise, it's going to be a bit odd, isn't it? But
Oh, I'm just thinking from the standpoint of
yes.
properties like sharing or
yes.
Yeah.
So what I'm going to do is I'm going to share the screen, and then I'm going to start off, and then I'm going to share the screen. So for each speaker, and then either Rachel or Kate are going to introduce each of those people.
Good.
But the last one, Sandip's, is a video, which I can't claim credit for this. We've updated or upgraded his PowerPoint so that it should come onto the screen correctly. And Kate's the introducer for that, not Rachel. And then at the end, the closing remarks are first from Kate and then from Rachel, followed by news on the website and the next meeting, which is from me, obviously. And then just a little bit about the next meeting, because we tend not to meet, we tend to forget. So let me just see who we've got here. Nagla is one of our ambassadors. Hi, Nagla.
Hi.
Catherine works with Poe, and I'm definitely not trying that high, and I'm just going to call it Poe Ear. I think that's easier. We're definitely going to get that wrong. Dorinda's an old friend of ours. That makes her sound old, but she's always here. She's a friend of Brent's. Leonie Morris is in the United Kingdom. She's one of our new ambassadors. She is has worked in the United States quite a bit and in India, and she is a psychologist or a psychiatrist. I never know which to say. Both.
A psychologist. I'm a psychologist.
Psychologist. There you go. Psychologist. Triggy is the first time, and Shirley. Shirley is wonderful because she comes to all different types of meetings that I'm involved with, and it's what a miserable life she has, isn't she? So hi, Shirley. So I don't know. We're waiting for Kate. We're waiting for a few people. So I'll just who should we get? Rachel, do you want to say a few words before we get started? Say about how you and I came together. And
yeah, so I was just thinking about that this morning as I was making my coffee, and getting ready for the day. I was like, wow, a year ago, Simon and I were just kind of brainstorming all the things we could do with the Neck Cancer Foundation. And, we never really imagined that, a year later we'd be having the first research conference and, we'd be surrounded by so many wonderful people and have so much support. So I was like, wow, it's really come a long way. And, it makes me really excited about today.
Thank you. Thank you. And Brent, from your point of view, how's it been from the beginning when I first came on your LACNets?
I think you did some good publicity for us, and I think you probably have 3 or 4 regular people, including one of the ambassadors. And this has been really good because it fills a need for.
I think it's Tanya. I'm not sure.
It's Tanya. Yeah.
Whoever's not muted, if because Brent's just trying to tell us the story. There's Professor Raj Thacker. Thank you for coming, sir, because we kind of need you.
Can you make maybe Brent co-host to mute people, or can we have a co-host that's on mute duty or someone?
Yeah.
I'd be glad to do that.
Yeah. So what do? How do I do that?
I think if you hit your view, you will get some participants.
Oh,
you'll
yes,
get some
more.
options
Yes.
to assign a co-host.
Yes.
You have up to 2 co-hosts.
Yes. No. I haven't. It doesn't show it. I must be doing something wrong. I'll come back to that if I may.
Okay. But anyway, the really neat thing about this particular group is it is very heavy on the research side, and I really appreciate that because we don't get that in the other venues that I sit in on. It's doctor level and very sciencey, and some of the others are kind of watered down from that standpoint. So this really fills in a significant niche for those of us who have been patients for a while, have done our studying, and are ready for that next chunk of and level of information. So this is great, and I'm really looking forward to today.
Thank you, Brent. Okay, so Kate, Kate Lyons, good afternoon in your case. I'm just waiting for some more people to join us because they're still joining us. 20 people at the moment. Would you, Kate and Rachel are going to be the co-hosts. I'm just going to do an introduction. to tell you what Neck Cancer Foundation is about. Lewis is there. He's one of our speakers today. Hi, Lewis. And Gayle's here. I've just seen Gayle panic over. She's here. Kate, would you just like to say a little bit about why you became an ambassador and what we've been doing, please?
Yes, sure. So, I mean, I think some of this has already been said, but I think one of the reasons that I became an ambassador for this was mainly because this was all about bringing together people, so researchers, clinicians, patients, and it was more about sort of the research discussions and bringing people together than it was that maybe, you know, in other places it's much harder to come by. So it's been a kind of unique opportunity for us. And I think as this sort of first meeting shows, we really have brought together a lot of people and have got people talking about NETs that maybe didn't necessarily know about it before.
Okay, thank you. Okay, so I'm sorry to be late in starting, but I'm just trying to let in as many people as I can. Let me choose somebody out of here who doesn't probably want to speak, and they'll be messaging me later. Jadira, hello, Jadira. Please tell us why you like Neck Cancer Foundation and what your role is as an ambassador.
Yes, thank you so much, Simon. I truly appreciate it. So one of the reasons why I'm so excited to be part of the Neck Cancer Foundation is, I think, as Kate said, you know, the goal is to bring people together. The goal is to bring patients, scientists, researchers, physicians, and because we all have a common goal. We all have a common goal to improve the quality of life of the patients, to develop more effective therapies for neuroendocrine tumors. And I think the only way that we can achieve that is by bringing it all together. I have to say, and Simon, you have been doing a fantastic job because you started all of this and you're doing a fantastic job on bringing it all together. And we are just kind of like following the mission that you have. And I think that everybody will agree that we've been finding ways to communicate and collaborate among all of us and as well helping patients. So, and the fact that this is kind of like one thing that's exciting about this conference is that you're bringing people all about the world. I think we have to, you know, this is a great initiative, and I feel like I'm excited to see what it comes after this. So thank you, Simon. And I'm the medical ambassador of the Neck Cancer Foundation.
Thank you very much. I think I might have actually blocked anybody else from entering by mistake, so I'm not really sure about that one, but I hope I haven't. Well, we'll see if anybody else joins. I clicked a little button on the bottom right hand side, and then it said I wasn't able to admit anybody else. So I hope I've successfully undone that. I'm not sure whether I have. So anyway, here we go. So welcome to our meeting, Neck Cancer Foundation. My name's Simon Robinson. I'm the founder of Neck Cancer Foundation. So you would say, well, what's neck cancer? I'm going to try and elaborate on that for you in very simple terms in a minute. But basically, we have 9. I live in London. I have NETs myself. I had PRRT in 2018, and I'm due to have some more PRRT in 2021. So that's my sort of, if you like, my claim to fame. So I run this organization. We do not have any donors. We do not have any sponsors, but we do fundraise. And we fundraise through our website. So sometimes people give us a little bit of money, but we're not really asking for money because we have 9 ambassadors who are here today. And those ambassadors are on the same platform as me, which is, as you can see on my banner behind me, research doctors and patients, bringing them all together. And scary as it might sound, and it certainly will to Professor Thacker, we're trying to find the cure to neck cancer. And as those of you know what NETS is, that's virtually impossible because it's different for every patient. Rachel, I'm going to have to ask you, I've got messages coming. I've gone and blocked out people from joining, and I don't know how to overcome the problem. I don't know whether anybody knows how to do that, but I can't see. This is what the danger of doing something live, isn't it? I've locked out people.
I have someone from a British newspaper who's locked out. I'd like to let her in, please.
Okay, I just don't know what to do it. I don't know whether anybody knows how to do that.
is there a way like someone else would take control on getting?
Hang on, I've unclicked it. So I think that should, I'm hoping so. This is very professional, isn't it? This is the danger of doing it live. Yeah, I've got 3 people waiting to be admitted, and I just don't know what button.
Well, we have about 3 minutes before the first talk starts, so we have about 3 minutes to get it sorted out.
I can invite people, looks like. So if anybody knows.
No, it's come back. You're right. It's back now. It is back now. Thank you. Thank you. So all my practicing's all failed. Sorry, Professor Thacker, because it's you to talk after me. So let's go back to what we're doing. So what is NETS? That they are coming back in now, Gayle. So it's not a problem. I've done something that's unmuted. It's pure magic. So what is NETS? For those people that don't know what NETS is, in very simple terms, basically it's a tumor that's in the endocrine system. So that's from the brain to the bowel. What happens is that you get a tumor, a person gets a tumor, often not discovered, often misinterpreted by professionals who don't know what neuroendocrine tumor is. Sometimes it's thought of as being IBS. Sometimes it's thought of all sorts of basic medical problems. So the ongoing from there is that the tumor then generates hormones, and those hormones create cancer within that endocrine system. And so often it's too late or it's too far down the journey for people to be cured from it. So that is a really difficult task for clinicians. Gayle's pulling her face. I hope I've got it right, Gayle. The clinicians have a really difficult task, because even if they know what NETS is, and it's still a problem, because the cure or the maintaining the condition has to be suited to the particular patient. So as an example, Dorinda, one of our patients, she has a different type of cancer to what I have, and so sorry, neuroendocrine tumor to what I have. So it's a question of somebody like, say, Nagla, who's one of our ambassadors. She has to find a cure for the area that she specializes in, and if it's not a cure, a way of maintaining it. So basically, that's what it is in layperson's terms. So we've got a 5:10 UK, so that's 12:10 EST. I'm going to put out what we're going to do is we've got 5 guest speakers, 2 ambassadors, Rachael Guenter and Kate Lyons. Rachael is in the United States, and Kate is in Oxford in the United Kingdom. And we've already done a little practice, sort of. And so they're going to introduce each person. So I'm going to hand over to Kate, and off we go with the meeting. Thank you.
Okay, thank you. So hello, everyone. So it's my privilege to introduce our first speaker, Raj Thacker. So Raj is the May Professor of Medicine at the University of Oxford. And there he works both as a clinical endocrinologist as well as heading the academic endocrine unit. And that is a research unit that basically is studying multiple aspects of endocrine disorders, including things like diagnosis and treatments for neuroendocrine cancers or tumours. Also, I've had the privilege of working there for the past 9 years. But Raj has had a long-standing career in endocrine research and NET research. And one fact that I also like to tease him, so he got his first research job the year before I was born, just to put things into perspective. But within that career so far, he has made some seminal contributions both to research as well as clinical practice guidelines, these of which have been acknowledged by multiple awards that he's received, including being elected a Fellow of the Royal Society and also being elected the current president of the British Society for Endocrinology. I'm sure many of you that are joined today also probably have already met Raj and know some of the work he's been doing, but today he's going to talk to us about what's on the horizon for NET research. So, Raj.
Kate, thank you very much. I'm going to try and share my screen, Kate, and I hope this works. Host disabled participant screen sharing, it says at the moment. I'll try that, see what happens.
Simon, I think it's up to you to give permission.
Yeah, I've done that.
I'll try again. Share. Right, let's hope this works. Yeah. Okay, I've got a big screen coming up now that's asking me to do all sorts of security things. You've got my slides. Shall we go that way?
I can try doing it. I mean, if you just say yes to the things that pop up, it should then share it.
Oh, right. Okay. It's got a thing coming up that basically says it wants to change my system preferences and all sorts of things, really.
I can try sharing them instead if you like. That might.
Yeah, it wants me to click to unlock my security system and do all sorts of things.
It's fine. I can try sharing them instead.
Yeah. Okay, let's try for that, Kate. You can tell we've, how should I phrase it, tried to make sure we've got everything prepared.
Can everyone see that?
I can see half the slide, Kate, not the whole one. Do you want to go full screen?
Bear with me. That it should be. Hang on.
I see the full screen now. It's just not in the presentation mode.
Yep. Is that sorry? It's because it was attached to my monitor. Is that better?
Yeah. Do you want to go full screen?
That should now be full screen.
Okay. Well, okay. So as long as everybody can see it, I don't mind. Okay. So Kate, you'll know roughly where to point anyway, so you can do that as I'm going along, if that's all right.
Yep.
Is that okay?
Can everyone see that? Can I just check? Can everyone see it properly before we carry on?
Yes.
Yep. Excellent. Okay.
See the power.
Okay. Kate, thank you very much, and thanks for patience, Era. Look, thank you very much for inviting me to join you today. As Kate's already sort of said, I work with Kate, and you all know what Kate hasn't told you in her introduction about herself is that she is absolutely one of the most dynamic people I've had the privilege to know, and she can be incredibly persuasive, actually, as you can probably gather why I'm here. Rachel, I can see you laughing and you know exactly what I mean, okay? I didn't quite realize what Kate had got me into, actually, until I started preparing the talk, and it's a talk about what is on the horizon for NETS. And I tell you how I feel right now, actually, in such a topic. I feel like Christopher Columbus in 1492, when he was sailing the ocean blue, as they say. And the thing is that you're looking at this horizon over there, and you don't quite know whether you're going to get to the promised land or you're going to fall off. And that's the dilemma we're in. And actually, when you think about new discoveries, new things coming, I always had to be very careful, because in my enthusiasm, sometimes I raise expectations too much, because the whole point about research is that sometimes you make some interesting discoveries, but they're really stepping stones for the next phase, really. So I hope you'll take everything I sort of mentioned in that light, in a way. And it's wonderful to be amongst friends. I've seen Kate here. Lewis is joining you from Portugal. That's lovely. Omer is also on the line. And these slides were, I had a lot of help in preparing these slides from Kate and Omer, who you can see there on the slide as well. And Sean, I think you're joining us as well, and I'm really delighted to see you're there. Sean and I worked together when she was in Oxford, but she's now in the USA. So Sean, welcome, and it's great to be with friends. So I'll tell you what I'd like to do. Can we go to the next slide? I'll just say next slide every time, if that's okay. No.
That should have moved. Can everybody see that?
No, unfortunately, it did not move.
Oh, okay. Well, that's a new. Let me try.
And some of us only see Kate lines have started screen sharing and no image.
It was going so well.
Yeah. So I
Let
think...
me stop sharing it and share it again and just check that.
Oh, okay. Now we're at the overview.
That's great. Yeah,
that works full screen. Great.
Brilliant. Okay, so Tim, what I'd like to do in about the next sort of 25 minutes or so is to just take you through a number of topics, about half a dozen of these, a little bit about neuroendocrine tumors. Simon's brilliantly covered this already, so I'll just touch on it briefly. Then a little bit about background to genetics and cellular mechanisms in cancer, because I think if we're looking at horizons and new things on the horizon, we've really got to understand why we're trying to study the genetics and cellular mechanisms of cancers and neuroendocrine tumors, or NETs, as well. And then a little bit about some genetic advances that have come through and how they're being applied for the diagnosis of NETs, the need for biomarkers and where we're going with biomarkers for NETs, and with what we've got right now, how are we using the treatments we've got for precision medicine, and then touch on emerging treatments for NETs as well, and then to try and summarize. So if you'll be patient with me, let's just see how we go on that. Okay, so next slide, please, Kate. Lovely. So neuroendocrine tumors, I think Simon said this so brilliantly, that almost everyone has their own story. And this is because neuroendocrine cells are in us, they're spread throughout our body. And when they form tumors, these can be anywhere. So I think perhaps calling it endocrine is a misnomer in that way, but it is correct because they do produce hormones and produce effects as well when they're there. So that's why they call that. So of course you can get neuroendocrine tumors in endocrine cells, so such as the pituitary, the adrenal, as you can see there on the left-hand side, and the ovary as well. But neuroendocrine tumors can also occur in what are so-called non-endocrine organs, such as the breast, prostate, lung, colorectal, and the stomach. Okay, so you know, that's why you get these tumors everywhere, and everybody has effectively their own story. And not only can they arise in isolation, but they can also arise as part of syndromes, such as this syndrome called the multiple endocrine neoplasia type 1 syndrome, which is characterized particularly by occurrence of parathyroid, which you see there in the neck, pituitary just at the base of the brain there, and the pancreas. There are tumors of those there. And this is a slide taken from one of Kate's articles that she published in Nature Reviews Endocrinology. So you can see that these tumors can arise almost everywhere. And that's one of the things that makes it very challenging for patients to get to the right doctors. And things makes it very challenging to get the right diagnosis, and makes it very challenging to treat as well. So we really have a tough task ahead of us. But having said that, we made lots of progress as well, which is what I'd like to tell you about in a while. So we go to the next slide, please. So let's go to this business about background in genetics and cellular mechanisms in cancer. And my apologies to those of you that are geneticists and cellular biologists, because I'm going to try and keep this as simple as I can, because that's about all I can ever understand myself. So next slide, please. So if we look at it this way, one of the reasons why we want access to these tumors from patients and blood samples and things is that we want those cells from the blood, tumor, or other tissues to extract these molecules, DNA that codes the genes, chromatin around which DNA binds, and I'll tell you a little bit about that in a while, RNA that is transcribed from the DNA, and proteins that are made from the messages that are contained in the RNA. And we can extract all of these things from the cells. And why do we want to do this? Well, if we have the DNA, we can study the change at the DNA level, genome as it's called. Chromatin, because the DNA is wound round chromatin, and when it does that, it has particular signals put onto it to say, be quiet or speak up, so to speak, okay? And this is known as the epigenome, and you may hear about epigenetics. RNA, because the DNA is decoded, shall I say, into these transcripts of RNA, which convey the message to the cytoplasm from which proteins are made. And that is called transcription, and that's a transcriptome. And when the proteins are made, that's called the proteome. So you often hear people saying, oh, we've done a transcriptome analysis. You now know they're looking at RNA, or we're doing a proteome analysis. That means they're looking at proteins. So that's the reason I just want to show that slide there to say that we're targeting, or we're looking at all these different components in the cells and the tumors to try and understand the signatures to tell us what are the mechanisms that are causing these tumors. So next slide, please. So how do we put this all in together? So in this cell on the left-hand side that I've tried to show there, you can see the DNA, the gene, the transcript, the RNA, the protein, etc. there. Now the proteins may remain in the cytoplasm to do various things, or they may actually come out of the cell. You can look at that right on the left-hand side there with the green thing, and they're secreted. And a lot of hormones are proteins and peptides like that. And they get into the blood vessel and they go and signal elsewhere. So this tells you how it all works in the cell, so to speak, okay? So let's go to the next slide now. So what we can do by studying all of those components is that we can try and then put them into cellular pathways, as we call them. And that's what I've tried to show earlier on about the DNA going to the RNA, to the protein, etc. And then when those proteins are there, if they can either be inside the cell, and that's shown in this light pink area, or in that cell, or they can be expressed on the cell surface, which is on the black line over there. Thank you, Kate, that's wonderful. And Kate's pointing to a very important receptor. That's a somatostatin receptor. And those of you that are on ultratryptophan lanreotide, that's the receptor it targets, okay? And then there are a host of other receptors there that you can have, and you can design molecules, as we say, these RTK inhibitors that I'll tell you about later on, that target these proteins on the cell to say, hey, stop misbehaving, okay? Or these mTOR inhibitors. And we could also design antibodies that were shown by those little Y symbols there as well, that target these proteins to say, you're misbehaving, so do be quiet, you know? And so the reason why I'm showing this is that we want to understand these cellular pathways, because if we can understand them, as I've tried to show there, we can actually use anti-cancer drugs to target them. And I've just shown you a few of those, but there are other ones which are called cytotoxic antibodies, antibiotics, antimetabolites. We have agents that actually target the DNA itself. And those are some of the real chemotherapy drugs that we use to treat these tumors and cancers as well. So by understanding the cellular pathways, we can figure out how to devise new anti-cancer drugs and how to use them. And sometimes we use monotherapy, i.e. one drug at a time. Sometimes we use combination therapy. And the reason why we want to understand these cellular pathways is that when we use combination therapy, we will target two different areas. So for example, you would not want to give two of the RTK inhibitors because they're doing the same job. You'd give, say, an RTK inhibitor and possibly a somatostatin analog. That would be a combination therapy. Or if you're going inside the cell, you'd give an alkylating agent and possibly an antimetabolite. You wouldn't want to target the same molecule. There's no point in that because you've done it, okay? So this is why it's so important for everybody to have an understanding of these medical therapies and why we use them, like those biotherapies that I've alluded to on the left-hand side, the chemotherapies, the alkylating agents, for example, and the immunotherapies. Now, I focus at the moment on the medical therapies because that's some of the stuff that's happening on the horizon as well, but also I'm a physician, but there are two important messages I want to give to you. I focus on the medical therapies there. Where you see the scalpel on the right-hand side, that's surgery. Surgery is really important. If you can resect that tumor, that offers the best chance for a cure. And what we do as doctors is we work in multidisciplinary teams. So physicians, surgeons, radiologists, we all work together. And the reason why we want to work together is we want to understand what's happening about that particular tumor or cancer, and then offer the best treatment that we can in our own specialities. And that all happens by working together. So surgery, best chance for a cure if we can take that primary out and there's no spread. And then the other one that's really very important, and Simon mentioned this earlier, this is peptide receptor radionucleotide therapy, or PRRT. This is an analog of one of these somatostatin receptors that I've shown up there, that Kate was pointing to earlier. And what's happened there is that we've attached a radioactive label, lutetium-177. And it's that combination, the dotatate, that gets it to the tumor, binds to that receptor, and it's that radioactivity with the lutetium that actually helps to whack that tumor cell and tells it to go away. All right, so you know, I hope I've explained some of the cellular pathways and the molecules and what we do here. So let's go to the next slide. Okay, so much so for the genetics and cellular mechanisms. How does the genetics actually help us in the diagnosis of NETs and things? So next slide. Let me give you an example. This is from MEN1. We know what the gene is. We know all the multiple tumors that arise. And because we know the gene, we can look for the mutations in that gene in patients using a blood sample. And genetic testing now, with screening and tumor surveillance in individuals who've got the MEN1 mutation, has changed the presentation of this disease completely. Once upon a time, this was a very much a symptomatic disease with end organ damage. Our patients coming in with kidney stones, massive gastrointestinal bleeding from ulcers, terrible problems with the pituitary, etc. Now, in a lot of patients in whom we found the mutation and we screen them regularly for occurrence of these tumors, we have gone from this terrible symptomatic disease to an asymptomatic disorder because we can pick these tumors up early. And the aim is that early detection and treatment of these tumors, remember I said, so if you can take them out surgery before they've done any mischief, that's your best chance of cure. Doing all of this, our aim is to improve the outcomes and the prognosis for our patients, okay? So let me tell you, okay, so if we're doing all this, what happens is we're screening now at younger and younger ages, and we screen children. So let's go to the next slide for a minute. So what happens here? So by doing what we call MEN1 gene testing or mutation analysis, we have done a study, and this is a study that Kate and Omer have just got into press in surgery. That what we're now able to do is to identify very young patients. We're talking about children, less than 18 years old, and whom we've done pre-symptomatic screening. And the graph on the right shows you the ages at which these tumors were detected. And if you look at the 18 years, you can see that lots of the patients had tumors detected before they were 18 years old now. And what we find is that 70% of these children had parathyroid tumors before the age of 18. 70% of them required surgery. About 35% had pancreatic tumors, and 55% of those required surgery. 30% had pituitary tumors, and 35% of these were called macroadenomas. These are big that compress the nerves coming from the eye and can cause blindness. And only 1% had adrenal tumors. But the good news is because we can pick these up earlier, we can treat them earlier and thereby avoid some of the more severe complications that can arise earlier. So screening at a young age is important, and that's what this paper says. So let's go to the next one. So the other thing that happens with these tumors is that everybody who we find clinically has MEN1 doesn't always have the mutation. And the question is, what's going on here? Well, one of the things we've done, and this is research that we're all engaged in, we found that, in fact, if it's not MEN1, there's another condition called MEN4. It's a slightly different syndrome. And I suspect there are more of those. But the good thing to look at here is that, first of all, if in those individuals who have the MEN1 mutation, if you look at the left-hand slide, they have the tumors developing much earlier than those that don't have the MEN1 mutation on the right-hand side in blue. And the other point is that if you look at the overall survival, okay, there is a 10% year improved survival in those that are mutation negative. In other words, if they have the MEN1 mutation at the moment, then this is not everybody who's had early screening, I hasten to add, the median survival rate in the MEN1 patients is 73 years versus not having the MEN1 mutation, that's 87 years. So what we want to do is to make sure that we improve that survival rate. Now, the other thing we find is that in these patients that have the MEN1 mutation, there is much more frequent development of what we call the pancreatic duodenal neuroendocrine tumors. The reason why I just want to focus on these is that these are the ones that really cause the problems, big problems, and they metastasize as well. So the more frequent development is the MEN1 positive, 60 to 85% of people will have pancreatic duodenal tumors versus the MEN1 mutation negative, it's about a third or less than a quarter, okay? So that it's important for us to know this. So what do we do about this if we've got these pancreatic duodenal neuroendocrine tumors? If you go to the next slide, please. Oh, dear. Is the right, oh, that's fine. For a moment, I thought the right-hand part was blank. I thought we were going to be in problems there. So this is some work, again, that Omer and Kate have done. And what we find is, first of all, that 70% of children, as I showed you earlier, below the age of 18 have the pancreatic tumors, and 70% of these pancreatic tumors are what we call non-functioning tumors. In other words, they're not producing insulin, which causes hypoglycemia and seizures. They're not producing gastro, which causes ulcers, but they're non-functioning. So the thing is, there isn't any hormone that seems to be secreted from them. And they're the sinister ones because you can't detect them. The only way you can detect them is by doing MRI scans. And so that's what we've done. And what we want to do is to pick these up as early as we can. Now, one of the things is that none of us wants to take out something that's not causing problems. So what we do is we follow these tumors up. And here you can see on the right-hand side, the size alteration in these tumors over a number of months. And you can see that some have not grown, like this little brown line over there, hardly moved at all. But then if you look at some of these other ones, like the orangey one over there, it's grown in a matter of about 50 months or so, from being less than a centimeter in size to being over 2 centimeters in size. And 2 centimeters is a cutoff that most surgeons use for operating on these. Now, when we do this, we found that actually a growth of greater than 2 millimeters is observed in 75% of these patients. So that means that over 10 years, if it continues like that, or often it doesn't, it's often exponential, it means that within 10 years, this tumor is going to grow. And there's a big debate amongst us right now as to whether we should wait till 2 centimeters or whether we should operate when we can reasonably at 1 centimeter, because you don't know when this is going to spread. And that is a big thing. So one of the things we're trying to do right now is to say, well, look, if we're observing these tumors, can we find biomarkers that might help us to determine whether the tumor is going to stay like that brown line, pretty flat, not grow and not cause any troubles, or whether it's going to grow rapidly like that orange line and cause trouble? So we really need biomarkers for prediction, detection of tumor growth, and as well as responses to the treatment and recurrence. So how are we going to find these biomarkers? So let's go to the next slide. So developing new biomarkers for NETs. So next slide. So here what we can do is you'll remember those cellular pathways I showed you. And what we want to do is to analyze the genome, the transcriptome, the epigenome, the proteome, and the metabolome of those cells and the tumor cells, and devise biomarkers against those. The other thing is that if we look in the bloodstream, we can look for the proteins and the metabolites that are there and analyze serum samples or plasma samples from the blood to find those exomes that are also secreted, and also these things called circulating tumor cells or circulating tumor DNA as well, because some of these cells will get out into the bloodstream, and those are the ones that may actually go and seed elsewhere and cause distant spread, or what we call metastases. So we want to study all of these components to see which are the best biomarkers. And there is a lot of literature out there on every one of these, and I don't have time right now, unfortunately, to tell you about them. So I just want to focus on one, if I may. Next slide, please. And this is on the circulating tumor cells. So if you look at this, we found that circulating tumor cells are shed from primary tumors. And for example, their analysis in non-small cell lung cancers it reveals tumor-associated genetic signatures that can identify patients destined to experience recurrence. That's really important. If we know that this person is going to have recurrence, we can target more treatments towards that. These circulating tumor cells can be detected in patients with neuroendocrine tumors. 43% of midgut and 21% of pancreatic neuroendocrine tumors have detectable CTCs, as we call them. And the presence of these CTCs is correlated with tumor burden and decreasing survival. So it's a pointer to that, which means we've got to target treatments even more. And these CTCs have a 40% sensitivity and 95% specificity for these sorts of tumors. So these are potentially new biomarkers that we can start using. And I think we need to develop these further so that they can become routine tests available to all hospitals and doctors as well. At the moment, there's still very much research tools that we want to try and roll out. Next slide, please. Okay, you will wave if I'm overrunning, okay, yeah? So let me go on to this other thing about emerging treatments and current treatments for precision medicine. Next slide, please. So you've seen this slide already, where I talked about medical therapy, surgery, and radiology, and I just want to focus on these medical therapies that we know at the moment and how we can use these for precision medicine. What precision medicine means is that we want to get the right drug to the right patient in the right tumor. Okay, so let's look at the next slide and see how we're doing this. So here we are, we've got the tumors. We've taken the tumors, and as I explained way early on about extracting those materials like the DNA, the transcriptome, the epigenome, etc., and analyze that. And here are the tumor characteristics. So that's very important. So for example, if a tumor has no or a low mutation burden, or has a what we call a non-actionable mutation, such as MEN1, and is expressing somatostatin receptors, what we would do for initial treatment is to use somatostatin analogs, that will be octreotide or lanreotide, if they're expressing this type 2 somatostatin receptor. If they're not, and they're expressing some of the other ones, like type 5 or type 3, we'd use this other somatostatin analog called pasireotide, which is available for some patients. So that tells you that pathway. If on the other hand, there is this pathway of this mTOR activation, which is an intracellular signaling pathway, then what we would do is we would use mTOR inhibitors, and there's a drug that's effective for that called everolimus that we would use in those patients and target the tumor in that way. If there is an increased mutational burden, such as DAX and ATRX, these are other genes that may be mutated here, and perhaps those tumors don't express somatostatin receptors, so octreotide and lanreotide are not appropriate there, we would use drugs against this pathway. These are the tyrosine kinase inhibitors, such as sunitinib, and we may also use, if they express the SSRT receptors, that we would use PRRT that we talked about earlier. If, for example, the tumors have expression of this molecule called programmed death ligand, this is one of the checkpoint inhibitors, and if you've got this, you can use immunotherapy, you can use targeted immunotherapy for that. And if they have P53 or RB mutations, these are high-grade tumors, then we would use appropriate chemotherapy for that. So it tells you, in a way, what are the best drugs to target against the tumors, depending upon what pathways are activated and what mutations they have. And of course, for non-responsive tumors, supposing the tumor doesn't respond to somatostatin analogs, we would use combination or adjuvant therapy, and that's where probably the immunotherapy is going to come in. So next slide, please. So I've told you, I want to move just in the last part to emerging therapies for pancreatic neuroendocrine tumors and neuroendocrine tumors. This is a complicated diagram on the left telling you all the different pathways, just to tell you how important it is to know about these pathways. And in the white boxes, you can see there, for example, the RTK inhibitors that I mentioned, the somatostatin inhibitors as well, some other intracellular ones, including gene therapy replacement here. And we've talked about the receptor tyrosine kinase and the mTOR inhibitors, etc. But the one I want to focus on just now is this one about the epigenetic modulators. If you could go to the next slide, just in the thing. Now, the reason why we can do this is that the protein that the MEN1 gene encodes for is called menin, and this has important roles in what we call the epigenome. Now, I can't see all of you, but this is where I believe in audience participation. So I would like you all to participate with me, please. Can you please all hold up your left hand? Okay, right. Hold it up, look at it, make a slight pocket with it. So just sort of, relax it a little bit. And you'll see a pocket right in the palm of your hand, okay? So just hold that there and hold it up against this figure that we've got on the screen. Now, if you're doing that, you are all holding in your hand the menin protein, because that's the way it's shaped. You can see that light green bit at the end, that's your fingers. The pocket that you made there is the palm of your hand. Your thumb is this other green one, and this orangey bit here, the N-terminal domain, is your wrist. See, this is crystallography. You can see how simple it is, all right? Simon, I'm not seeing your hand out there. Thank you. Okay, yeah. And the key thing is this pocket is where the drugs bind, okay? MLL, there, okay? Now, by doing this, menin regulates gene expression by histone methylation or acetylation, and this is where the epigenetic mechanisms are and where we can target drugs. So if you can go to the next slide for a moment, and this is work from Kate over here. She's used here an epigenetic pathway inhibitor. These are a new class of anti-cancer drugs. She's used JQ1, that's an inhibitor of histone decoding, and this is in a mouse model that she's looked at and treated. So if you look on the left-hand side of that green slide, you see there's lots and lots of pink in there. That's our control tumor from the mouse. It's got lots and lots of pink bits, and the pink bit tells you those are the cells that are proliferating. That's very active tumor. When Kate's treated all of this with JQ1, look, the pinks disappeared. Okay, it stopped it proliferating. It stopped this tumor dead. And I can tell you that because we've done another measurement called apoptosis, which measures cell death, and that's gone up. So we stop proliferation and we kill the cells. Magic bullet. We got to get it. We got to work on this to make sure that such epigenetic inhibitors are available for our patients, and indeed they are coming that way. Here's another one called etinostat, which is an HDAC inhibitor, acts on a slightly different pathway over here as well. Okay, so that brings you about some emerging therapies that might be coming. So next slide. Okay. Kate, have I got time to go for CAR T cells, or are we running out of time? Don't know where we are.
Go for it, because we started a little bit late. We just might skip questions.
Okay. I'll just go through this very quick. I've told you a little bit about immunotherapies, and this CAR T cell therapy is really emerging. It's right frontier medicine stuff. Okay, and Alison, who got the Nobel Prize about 3 years ago, got it for immunotherapies and CAR T cells. And here what we're doing is, this is really precision medicine at its heart. So what we do is we take a blood sample from a patient and we extract T cells. These are immunologically active cells. They're the ones that recognize what's you and what's foreign to you, if you sort of see what I mean. And they will activate the immune mechanisms for that. We take those cells, and then in the lab, we actually get them to express something that's actually on the tumor. So in neuroendocrine tumors, for example, that would be a somatostatin receptor. Okay, so we do that. We then grow them, millions and millions of those, put them back in the patient. So these cells will go in there and say, I'm looking for anything that's expressing too much somatostatin receptor, because if it's expressing too much somatostatin receptor, I'm going to latch onto it, activate the immune system, and tell it to come over and kill it. Okay, and that's what that shows you there on the left-hand side. So these CAR T cells, generating these is a challenge, because you can imagine it's going to have to be done specifically for every single patient. There's a lot of lab work that we'll need to do in sterile conditions and make sure that what we're putting back into the patient is really top grade stuff. And you can imagine this is challenging, but it's all doable. The only big hurdle at the moment is finding those molecules to target, and 2, expense. It is expensive. Okay, you might hear a lot about these things in the news in due course, but really, I think, the future, we've got lots of armamentarium coming out in the future. Epigenetic drugs was one thing I mentioned, gene therapy, CAR T cells, and a number of other drugs as well. So next slide, please. Okay. Oops. Okay. So I'm just going to summarize here. I hope you all know about NET being a significant cause of morbidity and mortality. I hope I've shown to you how there are genetics, complex syndromes, and how looking at those can help us with genetic approaches to helping the diagnosis and identifying individuals at risk of developing NETs. I think definitely better treatments are required for NETs. We do have some good ones, but we need better ones. And that we can get these better ones by undertaking some genetic and biological studies of these NETs, either with the associated syndromes or non-associated syndromes, and identifying novel pathways and designing drugs that target NETs as well. And that things like epigenetic modulators and CAR T cells represent new classes and new methods of treating these cancers. Next slide, please. I really want to thank everybody who's worked terrifically hard in the group. You can see Kate over there, and I think Sean's in the audience as well, who's there in the blue stripy t-shirt above over Kate there. And Omer joined after this photograph was taken, but you've seen his photograph earlier. And last slide, please. And I'd like to thank all the friends who help us with these drugs and studies, including Novartis, who made the pasireotide available. And of course, all of you who generously come and support us and make us aware that when you're having surgery or certain treatments, and voluntarily make that tumor available to us or blood samples available to us to undertake these studies so that we can actually come up with better treatments, which I think are on the horizon as there are biomarkers. I'll stop there. Thanks a lot, Kate.
Well, we'll do a virtual round of applause. No. Thanks very much.
Overrun there or not? I'm sorry.
No, well, we started a bit late, so I don't think it's your fault that we're running a bit late. So, I mean, first of all, thanks very much for going through that. I think that was a great overview. For the record, also, I am, of course, only 21. So when I said about your research career, then, you know, obviously, well, it's not too bad.
Thank you, Kate. I'll bear that in mind.
Yeah. I don't know whether, if anyone's got any questions, the easiest thing might be just to put them in the chat. And I think, unfortunately, Raj is going to have to disappear off in the not too distant future, but maybe if you could put those through in the next few minutes, Raj might be able to type some answers for you in there rather than us discussing it, and then we can move on so we can get through some of the other talks.
Okay.
Okay.
Well, if you put them in the chats, if I've gone, Kate, if you let me know what they are, I'll try and reply to them.
Yeah, and I mean, I'm contactable on Twitter and things like that. So if any of you've got any questions, I can pass them on and then relay them back. But anyway, thanks. So Rachel, over to you.
Yeah. All right, that was an excellent talk. Thank you. Thank you. So I am very, very excited and honored to introduce our next speaker, Gayle Morell, and it is great to have her talk today. She is a patient with neuroendocrine cancer, and she's here to tell her story and her experience with NETs. So she's a patient of Dr. Doricio. Gayle works full-time, and she has 2 children, and she's married, and actually one of her children was a surprise, and she had this baby while she was on Sandostatin, and so she may tell us more about that. And Gayle also has participated in the ACS Relay of Life for, I guess, over 18 years now. So we are very excited to have her today, and I'm very excited to hear her talk. So Gayle, I will pass it over to you.
Thank you, Dr. Rachel. Rachel just became a doctor, so we can't stop saying it enough. Thank you, everyone, for having me. My name is Gayle Morell. I live in the United States. I'm in Florida, originally from New York. And I have neuroendocrine carcinoma. Most people say, what is that? Obviously, this is the one place I don't have to explain, which is wonderful because it's like a safe zone. But I wanted to tell you today a little bit about my experience, and I know that my experience is not atypical. There was a book that I read when I was first diagnosed by a fellow patient called But You Don't Look Sick. If you look at me, I look like everything's fine, everything's, the same. But inside, my body is falling apart. I call myself the fire sale. I've lost a little of my lymph nodes, I've lost a gallbladder, and so they keep taking piece by piece, but I'm still here. So I am 46 years old, and when I was about 20, I started having almost like panic attacks with my stomach. I would be in the car, I'd be traveling, and all of a sudden I've had these really sharp pains. Not very long after that, my parents, who are actually very, very supportive and wonderful advocates for me, took me to every doctor that they could. And I kept hearing, well, you just have one of those nervous stomachs. You have irritable bowel syndrome, Simon. You have just this really, really violent digestion. It goes really fast. And so there were so many excuses that weren't a real diagnosis. And things began to escalate. It will be 11 years next week, the first hospitalization from the time where I just couldn't sit at home anymore because I was worried about myself. I was about 230 pounds. I'm 5'10". So, it doesn't sound like a lot, but it is. I could not lose weight no matter if I was on a diet with a doctor. Nothing was happening. My life was basically on life support right? My whole body was saying, you can't do anything else. You can't lose weight, you know, you can't try anything new. And I have thrown away tens of thousands of dollars trying to find out what was wrong with me. I was once admitted for 3 weeks to a teaching hospital down here, University of Miami, which is a wonderful place. And in all that time, they would have me twice a day. They would send in the students and give me instruction. They would say, you know, give them your entire history, give them too much, only answer. And I became a medical enigma, and they were just hoping that somebody would figure out what was going on. This went on for 3 weeks. So the only thing that came out of this, which was very good, was you have mastocytosis. Great, that's something. Okay, let me follow up on that. So I live in South Florida. My father, who drives everywhere with me, we got in the car and we drove all the way to Gainesville, which is 5 hours. And we did it in one day, and we turned back around because I still work full time. And in addition to being sick, you know, I get 6 sick days a year. That's it. So I have to make it work. Luckily, I have an accommodation. I do work from home full time. And so that makes my life a lot easier. I'm not restricted by clothing. I can take medication when needed and such. But we were coming up on, I started having the issue when I was 20. Now, in 2012, which is 11 years ago, I'm sorry, 9 years ago, I had gotten in touch with the right doctor. I was just so lucky that this gastroenterologist was assigned to me during one of my many hospitalizations. And he said, I'm going to try something. Are you open? I said, I'm open to anything. I mean, I have been through all of it. I am so ready. And he said, okay, I'm going to come back tomorrow. I'm going to hook up a new medication and I'm going to come back tomorrow. Okay. I'm looking forward to it. 12 hours later, I was sitting in my bed going, I don't even know why I'm in the hospital. I felt amazing. He comes later that night and says to me, how do you feel? I said, I feel amazing. He goes, you have cancer. He had hooked me up to sandostatin. And suddenly I felt like normal. I felt normal. And so long path, but I had a central line. I had 24 the sandostatin running until we learned about other things like short acting and long acting, but that took years. And so while I was still looking, the doctor in Gainesville from Shands had said, listen, you have mastocytosis. If I were you, I would follow up with Dr. Odorizio. And this was a long time ago. I know Dr. Odorizio is now not working as much as he did. And so my father and I spent a week flying to Iowa from Florida. Now, someone who's not good in a car is great on a plane. I don't remember the trip to or the trip back. I'm pretty sure my father just held my hand and I just followed him. So lucky that it was my dad. So when we got there, day 2, the first day that you're there, they take your blood and they get you ready. Day 2 is the scan, and day 3 are the results. Dr. Odorizio walked in and said, we got him. I said, what? He said, we got him. My father said, what does that mean? He goes, I can count all these tumors because I can see them. So I finally had a diagnosis. I just started crying. He said, honey, it's okay. It's all right. Just relax. And I said, it's not that. This is like the 16th year I've been told. And right before I saw Dr. Odorizio, there was a GI who told me that all the pain was in my head and that I needed to seek psychological help, that this was symptomatic of depression. And then to go from that to being diagnosed 3 months later with cancer was a refreshing experience. And Dr. Odorizio understood what I was talking about. And I got to connect with other people who knew what I was talking about. We've missed some great opportunities in this field, unfortunately. I just spent 8 hours watching a National Geographic biography about Aretha Franklin. They didn't even mention she died of cancer, let alone what kind of cancer. That would have been a lot of press that would be positive for us. Dustin Diamond, Screech, he just passed away. Everybody knows him around the world. If anyone said that this was neck cancer and someone said, hey, what's neck cancer? We could have gotten a little bit there. Steve Jobs. I mean, Steve Jobs impacted everybody's life. Whether you use iPhone or don't use Apple technology, Steve Jobs changed the world. He had pancreatic cancer. No. I think that Dr. Lewis would be really upset if he heard that. But that's what we keep missing. Dave Thomas, who's the founder of Wendy's with an adopted daughter, he found it too. And these are all missed opportunities. And so, I mean, I think I am so proud to say that there are 32 people on this phone right now. And this is all word of mouth. And there are so few of us. And we all have different experiences. About 2 years ago, I lost 100 pounds in 6 months. So before that, we had gone seeking an opinion at Moffitt. There was a doctor you had to qualify with to get to Dr. Strasberg. And if you didn't qualify through this doctor, you couldn't get there. It was before I had lost the weight. Says, well, if you lost about 40 pounds, you'd probably feel better. I don't even think you have cancer. I came with a diagnosis and a scan in my hand from Dr. Odorizio. Oh, I'm sorry, you don't think I have cancer? Great. I still encounter on a daily basis a lot of, but you don't look sick. I don't know what people want me to look like. Do they want my head to be shaved and I'm supposed to be swollen? There is no one look for us. We are zebras, right? We look healthy sometimes we don't, but for the most part, we don't look like your typical cancer patient. And the one thing is because it's so hard to get a diagnosis, I know that many of us have lost family and friends who thought we were dramatic. So I really, really want to thank all the doctors, all the researchers, and all the patients who've joined today. And I have some family and friends on here. I was hoping that they would learn more about my cancer, and that's my support system. I'm so grateful to have them on here. But that explains a lot. And the thing is if I had breast cancer, everybody would be wearing pink, right? If I had pancreatic cancer, everybody would be wearing purple, and they know what to do. There's pecan, for breast cancer, there's no end of supply of things that they can do for breast cancer patients. But we're still fighting to be recognized as a real disease. Just because I don't look sick does not mean that I am not. And we need to continue the good work that we're already doing through the foundation and telling our stories, whether you're a researcher and stumbled over this and were fascinated and just got stuck, you chose a hard path, but the zebras appreciate it. And so I just wanted to thank everyone for showing up and listening to a little bit about what it's like. On average, it takes 7.5 years to be diagnosed. I was just short of 17. And I'm telling you, I've lived in New York City. I've lived in Miami is a big area. It's not like we're hurting for doctors. There's not enough education about this. And so thank you so much for attending. And thank you for working hard to bring awareness. Thank you.
So much, Gayle. I almost cried there for a second. That was, beautiful for you to share your story, and it was brave for you to come on. And I think we all really, really enjoyed that. I think we have about maybe a minute if anyone has anything to say before we move on. But thank you again, Gayle. And there is a lot in the chat too, so make sure to read that as well.
Well, thank you so much. I will check out that Reels, the autopsy, because I do watch those. But here's the thing, right? We really, really have a tremendous opportunity here, and we keep missing them. We just have to keep it our mission, because the more people we tell, the more people who know, the more people who will ask, have you looked at carcinoid? Have you been checked out? So thank you so much for having me.
Thank you, Gayle. All right, so I will let Kate introduce our next speaker, and you guys can continue to talk in the chat as well.
Okay, thanks. So again, it's my pleasure to introduce our next speaker, who is Luis Cardozo, who is a research fellow at the I3S Institute for Research and Innovation in the Health of the University of Porto. He's also a consultant endocrinologist at the Faculty of Medicine at Coimbra University Hospital. And he's going to talk to us today about the genetics of NETs. Luis, over to you. Hopefully you can share. Oh, yeah, perfect.
So, good afternoon. Thank you very much, Kate, for your kind words. I would also like to thank the Net Cancer Foundation for the kind invitation to talk about genetic landscape of syndromic NETs. And of course, it's always a pleasure to be among friends. So this is our agenda for the talk. Approximately 20% of neuroendocrine tumors have a genetic cause, and this is even higher in the case of pheochromocytomas and paragangliomas, where the proportion may reach 40%. On the other hand, neuroendocrine tumors are a component of more than 10 genetic syndromes. For instance, MEN1, MEN2, MEN4, pheochromocytomas, paraganglioma, Van Nipper-Lindau, among other syndromes that we will talk about in next slides. I will not go into details about multiple endocrine neoplasia type 1 because Professor Thacker has already talked about this, but we know that this syndrome is caused by biallelic loss of the MEN1 gene. Most of these mutations are inherited, but approximately 10% are de novo mutations. And in 10 to 30% of patients, we are not able to identify any MEN1 mutation. And as Professor Thacker stressed out, it's very important to get a diagnostic, molecular diagnosis, because if we have that diagnosis, we may be able to detect tumors in the presymptomatic stage and improve the prognosis. As you may recall, Thacker identified that, mentioned that these tumors occur at very early ages. And if you we can notice here that before the age of 20 years old, approximately half of the patients already have biochemistry manifestations, and this number even goes higher after 40 years old. When we look at the gene, Manuel Ems and Professor Thacker reviewed a few years ago more than 1,000 mutations of MEN1 gene. And we can see here that mutations are widespread across the gene, and we are not able to identify any hotspots. And we are not able as well to establish any genotype-phenotype correlation. Regarding the mutations, we may see here that most mutations, approximately 70% of them, predict premature truncation of menin, so a loss of function of the protein, mainly arising from frameshift mutations, nonsense, and splice site mutations. However, in approximately 30% of the missense and in-frame bell mutations, we are not able to firmly establish this behavior, and so we may require further studies to establish if these mutations are pathogenic or benign. Regarding the importance of establishing the molecular diagnosis, again, Professor Raj already stressed this out, but I would like to call to your attention in the scenario when the detection of MEN1 mutations fails. So we do not have a mutation in the MEN1 gene. So in this scenario, it is important to look to other causes, what we call some phenocopies. So other disease that share the same clinic or that mimic the same clinics as MEN1. In this case, for instance, mutations in CDKI, we know that they occur in the MEN4 syndrome, CDC73, in some forms of hyperparathyroidism, calcium sensing receptor in FHH, again, RAT, in the MEN2 AP associated with pituitary tumors. So it's very important to study these phenocopies because without having a molecular diagnosis, it's much more difficult to counsel the patient and his or her relatives regarding the penetrance of the disease and about tumors they might expect. On the other hand, if we do not establish a molecular diagnosis, we are not able to undertake the most appropriate screening protocol because they are not defined. All these genes are responsible for approximately 5% of these phenocopies. And talking about cyclin-dependent kinase 1B, this is the most frequent mutation associated with MEN4 and is responsible for 3% of phenocopies. And when we compare the type of tumors that patients with MEN4 present, we notice that parathyroid tumors are, again, the most frequent ones, but the second most frequent ones are not duodenal pancreatic NETs, but the most frequent ones are pituitary neuroendocrine tumors. Again, no prolactinoma has been reported so far, and we know that this is the most frequent functional tumor present in MEN1, and the prevalence of duodenal pancreatic NETs is not up to 70%, as is the case in MEN1, but up to 25%. We should bear in mind that MEN1 may be the cause of familial isolated hyperparathyroidism. And in this case, we should consider that we have a possible diagnosis of familial isolated hyperparathyroidism if the patient develops the tumor, the primary hyperparathyroidism, at a later age than the typical one from MEN1. And we noticed before, we saw before, that by the age of 40, almost all patients have biochemical manifestation of MEN1. So if this hyperparathyroidism emerges at older ages, and if no further manifestation of MEN1 is seen during a follow-up of at least 10 years, we may be in fact under diagnosis of familial isolated hyperparathyroidism. But we should take in consideration as well that CDC73 and calcium sensing receptor mutations are also associated with this syndrome. Another case of hyperparathyroidism is the hyperparathyroidism jaw tumor syndrome. It is characterized by parathyroid tumors associated with ossifying jaw fibromas and renal tumors and uterine lesions. These patients have a lifetime risk of 15% of developing parathyroid carcinoma. Multiple endocrine neoplasia type 2 is a very, very important syndrome, is less frequent than MEN1, and the hallmark of disease is medullary thyroid carcinoma. We may see two phenotypes, MEN2A and MEN2B, or also called MEN3. The MEN2A is characterized, as I said, by medullary thyroid carcinomas, but also pheochromocytomas, hyperparathyroidism, and in some patients, cutaneous lichen amyloidosis. MEN2B is characterized by a medullary thyroid carcinoma that starts at very, very early ages and is associated also with pheochromocytoma, but no manifestations of parathyroid tumors is described, and a marfanoid habitus is typical, and as well the presence of mucosal neuromas. This is caused by activated mutations of rats, and in the case of MEN2A, most of these mutations are inherited, but in the case of MEN2B, most of these mutations are de novo. On the contrary to MEN1, we can see here an hotspot in exon 11 and in codon 634. Indeed, more than 95% of the mutations associated with MEN2A are located in exon 10 and exon 11. Regarding the MEN2B, we can see here that's an hotspot in the codon 918 that is associated with high risk of developing medullary thyroid carcinoma. And indeed, we see here a correlation between the genotype and phenotype. For instance, only patients with mutations in exon 10 manifests with Hirschsprung disease. The same goes for cutaneous lichen amyloidosis, that is only a characteristic in patients with mutations involving codon 634 and 804. As I said earlier, the codon 918 is associated, mutations involving this codon are associated with highest risk for medullary thyroid carcinoma, which may appear as early as during the first year of age. Another group of NETs is the familial cases of pheochromocytoma and paraganglioma. These tumors are rare. They occur mainly in the adrenals, but 10 to 15% are metastatic. As I said earlier, approximately 40% of cases have an underlying genetic cause. More than 20 genes are involved, but most of the mutations are associated or involve the SDH subunities. 3 gene clusters have been identified. This one, the first one, that's the pseudoepoxic signaling, and this signaling pathway is activated even though there's no lack of oxygen. This can be done indirectly by mutations affecting fumarate hydratase or the SDH subunits, as I said before, or directly through mutations affecting VHL or HIF2A. These mutations activate the hypoxic signaling, which leads to proliferation, angiogenesis, invasion, and metastasis. The other gene cluster is this one, the kinase signaling, involving mutations in RET, in NF1, MAX, or TMM127, which lead to the activation of P3K and mTOR and MAP kinase pathways, leading to proliferation, apoptosis escaping, and ultimately tumor progression. The last cluster is the wingless signaling, but no germline mutation has been reported so far in this cluster. The clinical picture is very heterogeneous, and it depends on the genes involved. But we can see here that, for instance, mutations involving VHL, NF1, RET, MAX, or TMM127 are mainly located in adrenals, so they are pheochromocytomas, and In the case of mutations involving VHL, RET, or MAX, most of these pheochromocytomas are bilateral. If we look into the SDH mutations, we see that they have an important extra-adrenal component, particularly SDHD and SDHAF2 are associated with head and neck paragangliomas. It is also very important to notice that patients affected by mutations in the gene SDHB are associated with the risk of metastasis up to 50%. If we look here, we see that in the first 3 decades of life, the most important genes are vanillin-indal, VHL, SDHB, and less frequently, but also relevant, SDHD. We may also establish a correlation between the genes affected and the biochemical profile. So patients with mutations in genes involved in the pseudohypoxic signaling produce mainly dopamine and noradrenaline, while patients with mutations in kinase signaling genes appear to produce more adrenaline. There are many other syndromic forms of neuroendocrine tumors, and as we can see here, neurofibromatosis type 1, vanillin-indal, polycythemia paraganglioma syndrome that we mentioned before by being associated with pheochromocytoma paraganglioma are also associated with neuroendocrine tumors of duodenum and, for instance, pancreas and again duodenum. Tuberous sclerosis is associated with pancreatic tumors and pituitary neuroendocrine tumors. Regarding a few words about the pituitary neuroendocrine tumors, there is an intense debate about changing the nomenclature from pituitary adenomas to pituitary neuroendocrine tumors. And this, the main arguments to change this nomenclature is because the term adenoma does not reflect the aggressive behavior and invasive behavior that up to 40% of pituitary adenomas have. On the other hand, pituitary cells uptake amines, and as we know, they have neurosecretory functions as well, and also pituitary cells, as we know, express chromogranin and synaptophysin, which are neuroendocrine biomarkers. These pituitary tumors are very, very frequent in general population, and in autopsy and imaging studies, they may reach up to 15% of the population, but only 1 per 1,000 patients per 1,000 populations are clinically relevant, and we will focus on these ones. So approximately 5% of PNETS have a genetic cause. They may appear isolated, for instance, in patients with AIP mutations, or in syndromic form, as we saw before, in patients with MEN1 and 4, in patients with pheochromocytoma paraganglioma, but also in patients with Isser syndrome, Lynch syndrome, and ESP8-related syndrome. Certain mutations, for instance, mutations in the kinase, are particularly important in patients with acromegaly, and in patients and mutations in the gene WESP8 are particularly important in patients with Cushing's, and this has been the main focus of my research in the previous years. So, in summary, early detection of genetic abnormalities is very important because it allows to release the family members that are negative from the follow-up stress, but it's always very important to establish a proper plan of diagnosis, follow-up, and therapeutic procedures. As we saw before, the genetic landscape of syndromic NETs is expanding, but we still need reliable protocols that are cost-effective and they are able to support the clinical decisions. So thank you very much for your attention.
Thank you very much. Again, we'll do a round of applause for you. I mean, so that's an amazing overview, and I think highlights two things. First of all, the complex picture we're looking at across the board, because I'm sure some of the patients that here might be able to associate with small parts of that, but you realize how big the whole landscape is. Yeah. Not only that, I think if you look at most of the studies you've quoted there, a lot of those are over the last 5 years. So I think actually what's also showing is how far we've come up that mountain. And I know also, I think, so I'll plug you as well, Louise. I know you're undertaking a study soon, hopefully starting a PhD program to be looking at, you know, the pituitary genetics. So we can relate a lot of this information we're finding from families into patients as well, that are getting sporadic, so either single tumours or that are occurring, so you're the first person in your family. I think in the interest of time, the chat seems to be working quite well for questions. So I think if anyone has any questions or anything generally they'd like to ask about the genetics of any of the tumours, then maybe put it in the chat and hopefully Louise can answer it there. So I'll now pass you back over to Rachel to introduce our next speaker.
All right, thank you, Louise. That was a very interesting talk. And I am now excited to introduce our next speaker, which is Dr. Hien Ear. She is an assistant professor in the Department of Surgery at the University of Iowa. We were lucky enough to have her present at our last Net Chatter event in April. So if you all were here, you got to hear a little bit from her then. But we are super excited to have her back and giving another talk. She does a lot of exciting and novel research around developing patient-derived models of neuroendocrine tumors. And so we're very excited to hear her talk today. So, Po, I will pass it over to you.
Thank you, Rachel. I will start sharing my screen and hopefully it will go well. But first of all, yes, I would like to thank the organizing committee, Simon, for the invitation to give this talk. Today, my talk will be focused on serotonin metabolism. So I don't have any disclosure. There are some pictures of mouse surgery during this presentation, but all the procedure that we're doing have all been approved by our institution. As Gayle actually stated earlier, so here in Iowa, we are actually a very lucky group. We are a great team of neuroendocrine researcher and clinician, and we form the University of Iowa Neuroendocrine Specialized Program of Research Excellence. And this is a program that is also recognized by the European Society of Neuroendocrine Tumor for Research Excellence. And our goal is really to bring novel therapy to patients. So as you probably notice, I'm actually not in this picture because I'm the new member. I'm the new recruit here because I wasn't initially trained as a neuroendocrine scientist. I was basically a biochemist with experience in protein engineering and doing drug screen and studying cell cycle regulation. And after that, I did my postdoc in metabolism. So, but I was recruited to this team, and I was awarded as a career enhancement program award for year 4 and year 5. So in my previous presentation, I talked about my award for developing the neuroendocrine tumor models for drug testing. So today I will focus actually on my year 5 award, which is on serotonin metabolism, because serotonin production is actually a very important part of neuroendocrine tumors. But first of all, I would like to go through the concept, the hallmarks of cancer. So these are actually biological processes that are important for cancer development. And we study them because we think that these are really the key for developing new drugs and for better targeting the tumor for preventing them to grow. And so these processes are really basic basic feature of the cancer biology, such as the process that inhibit the tumor from growing, the processes that these tumor develop in order to escape our immune system, and for other examples are, for example, the cancer cells can divide indefinitely. But I will skip some of these because so my area of expertise is actually in metabolism and cell cycle regulation. And this is why I decided to focus on serotonin regulation in neuroendocrine tumors. But it's also what I've come to realize is it's also, I think it's an area that is really in need of attention because serotonin metabolism is really causing a lot of complication for neuroendocrine tumor patients. And I've learned this through our healthcare experts as well. And so this is why I decided to focus my research program on this. So, but first of all, just a brief overview of serotonin. So serotonin is this nice little molecule here. It's actually a derivative of an amino acid called tryptophan. So for the rest of my presentation, I will represent it as a cartoon of this little blue molecule here to represent serotonin. Now, serotonin is being synthesized in our body naturally. And we actually have two genes that make serotonin. So these genes are called tryptophan hydroxylase, so TPH, and we have TPH1 and TPH2. So TPH1 is mainly expressed in the gut, while TPH2 is in the nervous system. Now, in the case of neuroendocrine tumors, it's mainly the TPH1 that is expressed in this tumor. And the fact that there is highly expressed, and the tumor makes a lot of serotonin, and this causes a lot of health problems, such as fibrosis for the heart, and also diarrhea, flushing. And often it's also really severe diarrhea. So this is why I think it's important to address this. So we started our study by looking at the level of this TPH1 enzyme in the neuroendocrine tumor from the small bowel. And as you can see, so this is the level of expression of the adjacent normal gut tissue. So it's quite low. And in the tumor, it increases about like 500 times. So it's really highly expressed in small bowel neuroendocrine tumors. Now, for the neuroendocrine tumors from the pancreas, it's also much higher expressed, but not as much as the small bowel neuroendocrine tumors. And this is probably why there's more patient with neuroendocrine tumors from the small bowel that metastasize to the liver that would actually develop carcinoid syndrome. So we also take the next step to localize where this enzyme, this TPH1 enzyme, is located in the tumor section. So this is a tumor section this is a patient tumor that we slice and then we stain for the TPH1 here, where we color in green using specific antibody. And we see that they are actually expressed in the neuroendocrine tumor cells and not the surrounding fibroblasts. And like I mentioned in my previous talk, like these neuroendocrine tumor cells actually like to be grown in clusters of cells surrounded by fibroblasts. And so from this tumor section, we locate the TPH1 protein that makes a lot of serotonin to really the tumor cells and not the surrounding fibroblasts. But this enzyme, so the process of making serotonin is actually a two-step process. The reason why we focus mainly on this enzyme called TPH1 is because this is actually the slowest step and the key step in serotonin production. In biochemistry, we call it the rate limiting step. But this is really the bottleneck of the reaction, because it adds a hydroxy group, basically an oxygen and a hydrogen group, to the molecule, the amino acid tryptophan here. And this is really hard to do. That's why this enzyme TPH1 is really a key factor to this. And then the other reaction is actually a very fast step, because all the other enzyme does is really cleave off, like trim off a little bit of this, and this becomes serotonin. Now, the reason why I want to elaborate on this is because, as many of you may know already, so TPH1, we actually have a very good inhibitor called, the drug called Zermello, or the chemical name is telotristat ethyl, and it inhibits, it's a very good inhibitor to block the TPH1 enzyme. So, and to more precisely, this is called a competitive inhibitor. But to bring everybody on the same page, so I will introduce review the concept of enzymes and substrates. So an enzyme is really a protein inside the cells that recognize a substrate and then make it into a new product. So for example, I think it's really an enzyme is a catalyst. So in another way you can see this is like, for example, Simon is a great catalyst. He recognizes us and he brings together a great group of people, and the product that we make is actually really amazing. We have this network of net researchers, scientists, and patients, and we together, you know, we actually help each other to move the field forward. So this is kind of like what enzymes do. They actually really move the reaction forward and make this product. Now, I will come back to this concept of competitive inhibitor. So the competitive inhibitor, meaning that, so this small molecule is actually binding to the same site as the substrate would bind normally, but then it will block it from making the product. So it will really stop the reaction. Now, this is all great, but the problem is that, you know, the substrate can still be around, and it can actually displace the enzyme, the inhibitor, or the inhibitor can be degraded, or the substrate can bind to a new enzyme, and then it can still make the product. So this is why I think you can see it, you know, on a positive note. It's knowing this type of mechanism actually opens us more door to develop new drug candidates, or to use them in combination, so that we would have a better blockage of the enzyme, right? So to bring back all this notion to the case of TPH1, which is this enzyme that is really highly expressed in neuroendocrine tumor. Well, the scenario of this enzyme is a little bit more complicated than that, because it doesn't bind the tryptophan and make it into serotonin right away. The reason is that this enzyme is an apo enzyme, meaning that it can't recognize the tryptophan by itself. It needs an adapter. So this green adapter here actually would fit into the enzyme first, and then it can bind the tryptophan and make it into serotonin. Now, why am I talking about this? Well, the reason, I know it's a little bit complicated, but maybe if you try to relate it into real life scenario, it's kind of like a car and the accelerator pedal, because like, you know, if you don't have gas in the car, you can push as much as you want on the accelerator pedal, but it won't move, right? But if you do have gas, then it would actually move. And this is important because, you know, this means that we have another opportunity to target this enzyme now. We can target this green molecule here. So overall, what I'm trying to say is that by studying the pathway of this enzyme and by knowing its biochemistry, we can come up with new hypotheses to better block it. So for example, here we hypothesized that by decreasing this BH4 molecule, we could further prevent serotonin biosynthesis. And when we could also combine this with the telotristat ethyl, and then we would have a better blockage. So this is what we did. We tried to see if we can actually prove this in a cellular model. So we seeded the neuroendocrine tumor cells, and then we treated with this different categories of drugs. So either a control, so this is the solvent control, or the NAMT inhibitor that reduced the BH4, the green molecule, and also another group is the telotristat, and then the combination. And so here, what I'm showing you is really the quantification of serotonin level in this cell. So what you see is that in the control, there's a lot of serotonin, and in the FK treated one, you actually have decreased serotonin level that is really significant. And with the telotristat, you have a further decrease. And when you combine both of these inhibitors, you actually have a very low level of serotonin now. So we can, these are in vitro assays that show that the combination of this two therapy is really promising for reducing serotonin level. So the next step is really to test it in an in vivo model, in an animal model. So luckily, so that this has been already developed in the past. So the model for carcinoid syndrome, the mouse model has been initially developed by Dr. Herb Chen's lab, and then it was further pushed by Dr. Mark Evers' group, where they use green fluorescent neuroendocrine tumor cells, and so that they can track them as they migrate to the liver. And then they did some drug treatment, and they found that, for example, octreotide can reduce the carcinoid syndrome. So this because this is a little bit of a complicated model, because it consists to try to mimic liver metastases in the animal model. So what they had to do is actually inject the cancer cells into the spleen of the mouse, and then the cancer cells will actually use the portal vein and then go to the liver and then colonize as tumors. So here in Iowa, we're trying a little bit of a variation to this, but very similar to what previously has been developed by Dr. Herb Chen and Mark Evers' group. So we inject our tumor cells into the spleen, but we are using a luminescent. So these tumor cells can be tracked because they use light. Now, the main advantage is that you can actually track them, the same mouse throughout time. So week after week, we can follow how the tumor metastases is going. And for example, for this mouse, on the first week, we see that we have very little tumor, but then even after 2 weeks already, it has a lot of tumors in the liver, and the liver is literally full of tumor cells. Normally a liver is more reddish color, and as you can see here, it's white because it's actually colonized by a lot of the tumor cells. So overall, we are trying to use this system to test our new combination drug treatment. So to summarize, today I've talked to you about how the enzyme that is responsible for making serotonin, this enzyme called TPH1, it actually needs a cofactor, this green molecule here, to actually bind serotonin or bind the inhibitor. So we can target this molecule as an alternative therapy, and we could use it in combination with telotristat ethyl, so that basically you're putting on the brake and you're making sure that the car doesn't move because it doesn't have any gas. And so this is how we wanted to see how we're targeting this system. And now we are trying this therapy in the mouse. So I will finish here, and I would like to thank everyone for your attention. I would like to thank our funding sources. Again, this was an award that I received by our NetSport group for studying neuroendocrine serotonin metabolism, and my mentors who are Dr. James Howe, Dr. Sue and Tom Odoricio, Dr. Quell, and my collaborators, and also my undergrad students. So we're not a very big group, but I am very fortunate. I have really smart and hardworking undergrads. So overall, that's why our research program is going really well. So thank you for your attention.
Thank you so much, Po. That was an excellent talk. And, you know, it's very important that we have people looking into the serotonin production by neuroendocrine tumors, because this is really impacting the patients. So it's great that your team is working on this and looking into this. So if anyone has questions, go ahead and keep doing that in the chat. Like Kate mentioned, that's going really well. And Po will be able to answer them. And so now I will pass it over to Kate to introduce our final speaker.
Thank you very much. So our final speaker today is actually Sandip Basu, who is based over in India. So this is going to be a recorded talk. But he is a physician of nuclear medicine at the head of the nuclear medicine academic program at the Radiation Medicine Center. And he's also the Dean Academic Health Sciences at the Homi Bhabha National Institute. So he's known for the work he's been doing in nuclear medicine, particularly on positron emission tomography diagnostics, and the PRRT that you've heard a bit about already today. Now I'm going to attempt to play the recorded talk. So hopefully this all goes well and you can hear it. But of course there won't be questions, unfortunately, afterwards, because he can't be with us now. But if you have any questions that arise during it, if you put it in the chat, we can maybe try and address them later on. So let me see if I can now share this presentation. Bear with me 1 second. Right, so can everybody hear that?
We can see it. I don't hear it yet.
Hello to you all.
Oh, there we go.
Outset, I would like to thank the organizers for having me in this academic activity. It's great to be speaking with all of you today. So in this treatise, we would be briefly exploring the theoretical concepts and practical aspects of NET theragnostics and our decade-long experience with lutetium dotatate-based PRRT in a high-volume center in India. For the purpose of systematic discussion, I shall make this deliberation in a few thematic points. Theme 1 is evolution of dual tracer PET-CT in NET theragnostics. The relative uptake of gallium dotatate and FDG in the tumor enables assessment of the dynamic tumor biology of NENs on a continuous scale, and this is utilized for clinical decision-making and personalizing the treatment strategies. We shall see this with a few clinical examples. This 59-year-old male, a postoperative patient of NET of head and body of pancreas, presenting with recurrent paraduodenal mass and with liver metastasis, both of which shows avid uptake on dotatate PET-CT. The MIB1 labeling index of this tumor was 1 to 2%. If you note the FDG PET-CT, both these lesions show negligible uptake, if at all. Vis-a-vis that, this patient, a 60-year-old male, presenting with 11 into 9 into 11 centimeter heterogeneous mass arising from pancreatic body and tail with liver metastasis. The MIB1 LI was 4%. So if you see the somatostatin receptor-based dotatate PET-CT shows avid uptake both in the large primary and the liver metastasis, whereas FDG PET shows partial concordance. Part of the primary and the liver lesions are showing FDG uptake. Now this patient who is a patient of 6.1 into 6.3 into 4 centimeter highly vascular mass of the unsigned process of pancreas with a MIB1 labeling index of 30% shows uptake, high uptake with both somatostatin receptor-based PET and FDG PET. This 25-year-old female of metastatic NET has a large volume mass of the body and tail of pancreas and multiple large-sized liver lesions with a CT-guided liver biopsy of poorly differentiated NECA with MIB1 labeling index of 45% shows high uptake on FDG PET-CT showing extensive disease, while the somatostatin receptor targeted Hien Ear shows no uptake in the primary or the metastatic sites, indicating this patient is not a suitable candidate for somatostatin targeted therapy and should be considered for chemotherapy at the very onset. Thus, if we note the evolution of personalized approaches in metastatic and advanced NETs, we shall see that Ki67 and grade of the tumors have traditionally played a pivotal role in the NET management. A number of other molecular alterations have signified disease prognosis, either associated with good prognosis or with poorer prognosis. But over the last decade, the dual tracer PET-CT with somatostatin receptor targeted PET and FDG PET-CT has evolved as a robust and significant additional clinical parameter that guides personalized strategies greatly. Thus, a well-differentiated low Ki67 tumors are usually SSTR positive and FDG negative and are candidates for somatostatin receptor targeted therapy, while a high-grade tumor is typically SSTR negative and FDG positive and are usually considered for chemotherapy. You have, of course, an intermediate group, which is a large number, and where both the tracers can be positive and are being examined for combined chemo-PRRT. We shall see the clinical examples of each of these in some of the later slides. Now, just a brief recap of the ligand chemistry for PRRT. The biological activity of all somatostatin analogs resides in the cyclic region of the matured peptide, and the disulfide bond between the two cysteine residues maintains the cyclic structure. Native somatostatin, that is somatostatin 28 and 14, has a short half-life of 2 to 3 minutes. Hence, analogs have been developed such as octreotide, lanreotide, fapreotide, and pasireotide. Most of them primarily targets the somatostatin receptor 2, which is the most important receptor for neuroendocrine neoplasms. It also targets to a lesser extent somatostatin receptor 5, while the pasireotide has a more universal affinity profile for somatostatin receptors. The analogs have both a short-acting formulation, such as octreotide has a short-acting formulation with T-half of 90 minutes, but more important clinically is a long-acting formulation known as LAR or long-acting release formulation. For lanreotide, the long-acting formulation is known as autogel formulation. In radionuclide therapies, that is PRRT, we employ a ligand or radioligand known as octreotide. So what is octreotide? When this threonenol residue in octreotide is replaced by threonine, it is called octreotide. Now, what really happens with octreotide? There is a 9-fold increase in affinity for somatostatin receptor 2 by the octreotide, and this translates into 6 to 7-fold increase in the affinity of their radiolabeled counterparts, ultimately leading to 4 to 5 times enhancement in the tumor uptake and dose delivery. Now, a brief on the radionuclides. The entire enthusiasm for PRRT got momentum with the availability of lutetium-177. 2 alternative strategies are available for production of lutetium. The first is the direct route, which involves the neutron activation of highly enriched lutetium-176 in research reactors with medium to high thermal neutron flux. The second route, or the indirect route, involves neutron irradiation of highly enriched ytterbium, which leads to formation of no carrier added lutetium-177. In this slide, the pros and cons of each pathway is tabulated. The blue colored fonts in each column demonstrate the positives, while the red colored fonts depict the shortcomings. Overall, the indirect route produces NCA category lutetium with higher specific activity product, but would require a high flux reactor and a complex radiochemical separation procedure. While in the direct route, the post-irradiation radiochemical process is much simpler, but you get a product of lesser specific activity. The next thing is defining the indications or selection of patients for PRRT. The classical clinical setting has been advanced metastatic or inoperable progressive NENs, primarily grade 1 and grade 2. The essential imaging prerequisite has been the high-grade uptake of Prenning score 3 or 4 on somatostatin receptor-based imaging. While the potential considerations have been significant extensive disease at diagnosis versus low volume disease and symptomatic functioning tumors which are uncontrolled by somatostatin analogs. The joint IAEA, EANM and SNMI guidelines mentions grade 1 or grade 2 metastatic NET as the potential indications for PRRT. But in practice, we come across a fraction of grade 3 metastatic NENs, especially those with a Ki67 between 20 to 30%, who are also frequently DOTA positive. So the question in this group of tumors is whether grade of tracer uptake on somatostatin receptor targeted imaging be the major determinant to select them for PRRT and break the barrier of histopathological criteria mentioned in the guidelines. This could be potentially explained by the recent changes in the WHO 2017 NEN classification. Amongst the number of changes suggested in this classification, probably the most important has been the recognition of a well-differentiated NET within the grade 3 neuroendocrine neoplasms, which could be potentially somatostatin receptor positive. This matches with the clinical notion, and over the last 4 to 5 years, this group of tumors, when they are metastatic, are also considered as potential candidates for PRRT. Now, we shall look at the gratifying PRRT results that we have obtained over the last 10.5 years in our setting. We have completed around 4,500 PRRTs over the last 10.5 years. Just to show you an example, this is a 70-year-old male, NET of body and tail of pancreas with hepatic metastasis, Ki67 10 to 12%. This is the baseline scan. The patient showed low-grade FDG uptake in the liver as well as in the primary. This is after 2 cycles, and this is after 4 cycles. Most of the liver lesion had gone, and the patient was considered for surgical evaluation of the primary. This is a 53-year-old female, a known case of atypical carcinoid of lung, Ki67 of 8%, with multiple liver, lungs, rib, and right-sided pelvis lesions. This is before the first PRRT and before the 3rd cycle of PRRT, showing excellent response to 2 cycles of PRRT. Interestingly, this patient had an FDG negative disease. Just to show you an example of excellent safety profile of PRRT. This 35-year-old female, a case of duodenal NED with Ki67 of 20%, presented with extensive bone marrow disease when she was referred for PRRT at our setting. with prior history of radiofrequency ablation and external RT, after which the disease increased significantly. The patient responded remarkably well after 3 to 4 cycles of PRRT, which started going for work at 5 years. This is the FDG scan. If you note, most of the bone marrow lesions which were DOTA positive were FDG negative. Only the primary in the duodenum showed uptake on the FDG. This slide demonstrates the long-term survival outcome in our setting, published in BJR in 2020, examined in a population of 468 patients of NET. The estimated PFS at 7 years was 71%, while overall survival was 79.4%. If you note the response parameters, on imaging RECIST 1.1 scale, the stable disease was 60%, while the partial response was 27%. On a symptomatic scale, the complete response was 45.7%, partial response was 23.1%, and stable disease was 25.2%. The theme 9 is an extension of what we saw in theme 1. When we consider a patient for PRRT, we evaluate the tumor characteristics by 2 tracers: the somatostatin receptor targeted PET by gallium DOTATOC knock or TATE, which evaluates the somatostatin receptor expression in the tumor, and the glucose metabolism by the tumor by FDG. The concept of dual tracer PET-CT in personalized clinical decision making has now become an integral component of metastatic NEN management and is considered by the medical oncologists and the nuclear medicine physicians alike to study side by side the 2 scans before making the clinical decision on an individualized basis. Those who do not have the germanium gallium generator or the PET facility in their center, they may use technetium-based tracer, Hien Ear, which has been quite popular in the places, remote places in Indian setting. There is one subset of patients in whom the tumor shows high uptake on SSTR and FDG PET-CT at baseline. That often demonstrates treatment resistance and shows high morbidity and mortality in the course of disease. We now know that this group of patients cannot be managed by PRRT alone. This patient is one such example. The next theme is to combine PRRT and chemotherapy to address this group of aggressive tumors. Since 2013, we have started employing sandwich chemotherapy, where 2 cycles of CAPTEM are clubbed in the interim 3 months between 2 PRRT cycles. This is one such case example that shows extensive hepatic metastasis with high uptake on both gallium dotatate and FDG PET-CT and shows excellent response to sandwich chemo-PRRT to a cumulative dose of 800 millicurie of lutetium dotatate and 12 cycles of CAPTEM, both by molecular imaging PET as well as CT RECIST criteria. This is the schematic protocol adopted for sandwich chemo-PRRT. As you will appreciate, herein 2 cycles of oral CAPTEM is sandwiched between 2 PRRT cycles. This is one more clinical example. A 33-year-old female, a diagnosed patient of pancreatic NET with Ki67 of 25% with extensive hepatic metastatic disease and showing high uptake on both gallium dotatate and FDG in 2016 at baseline, shows near complete response in 2018 to a combined chemo-PRRT schedule with a cumulative dose of 1 curie of lutetium dotatate and 12 cycles of oral CAPTEM. In an analysis in 2020, we observed in a population of 38 patients who had received this regimen since 2013, disease control rate on a RECIST scale was 84% in this aggressive group of tumors with this combined chemo-PRRT regimen. The second area where this sandwich chemo-PRRT regimen is potentially useful and routinely adopted in our setting is this group of tumors, which is of course a small subset of patients where there is heterogeneous tracer distribution. This patient has got SSTR avid liver lesions, while the bone marrow lesions are negative primarily or low grade on SSTR PET, but are high on FDG. Thus, in summary, we can see that along with histopathology and Ki67 index, dual tracer PET-CT forms a robust and simple additional tool in clinical decision making in metastatic NENs. The next challenge is succeeding in neoadjuvant settings. Typically, the resectability of a primary pancreatic tumor is determined by 3 points: superior mesenteric or SMA encasement greater or less than 180 degrees, any celiac artery abutment in CECT, reconstructible or unreconstructible SMV or portal venous occlusion. In either of the cases, distant metastasis or metastasis to lymph nodes beyond the field of resection forms a contraindication. This is one clinical example of locally advanced pancreatic neuroendocrine tumor showing excellent response following neoadjuvant PRRT of 850 millicurie of lutetium dotatate. In an analysis of 57 patients at our setting, the inoperable disease became operable in around 26%, that is 1/4 of the patients who were treated in a neoadjuvant setting. Thus, if we analyze the challenges associated with metastatic NET treatment, they are primarily twofold. The first is biology driven, high grade uptake in the tumor on FDG PET. And this is approached with the combined chemo-PRRT regimen. The next one is size driven, large volume tumors. And this is approached by combining the lutetium dotatate with a higher beta radionuclide such as yttrium-90, either with a duo PRRT approach, which is followed at our center, or with tandem PRRT approach. The role of alpha therapy with actinium dotatate is at present evolving and is being examined at various steps. This is a clinical example of duo PRRT with yttrium dotatate following treatment with lutetium dotatate in large volume NET. You can see the Bremsstrahlung imaging, which is the primary mode of imaging with yttrium-90, and also the feasibility of PET-CT imaging with yttrium dotatate. We typically employ the duo PRRT protocol for large volume lesions, a lesion size of greater than 5 centimeter in metastatic and advanced neuroendocrine neoplasm setting. The next theme is dosimetry with the indigenous product. Our health physicist has done a rigorous dosimetry with the indigenous product. Not going much into the detailed analysis, the formulation has demonstrated good comparable result with the literature reports and equivalent dosimetry in the lesions as in the normal physiological organs such as kidney 0.72 versus 0.55, bone marrow 0.04 versus 0.03, total body 0.07 versus 0.05. So roughly they have compared well with the available commercial product. Theme 14 is stretching the boundaries of theragnostics and extending the range of tumors where PRRT is employed. The commonest group of tumors in our setup where PRRT has been employed is metastatic GEP-NETs and pulmonary NETs. The next group of tumors are metastatic medullary CA thyroid. The other tumors where it has been employed is metastatic Merkel cell CA, recurrent inoperable phosphaturic mesenchymal tumor, sinonasal NEC metastatic insulinomas, non-iodine concentrating METs of GTC that show high uptake on DOTA-TET scan, and metastatic pheoparaganglioma and neuroblastoma that is MIBG negative. This is the relative distribution and pie chart of the spectrum of malignancies treated with PRRT in our setup in a population of 1,000 patients. JEPNETs 78.1%, CUPNETs 8.7%, metastatic MTC 5%, pulmonary NETs 3%, mediastinal thymic NETs metastatic 2.7%, pheochromocytoma paraganglioma 1.5%, and other miscellaneous tumors 1%. Now, while the vast majority, I would say 85 to 90% of PRRTs have been delivered primarily in tumors with neuroendocrine in origin, there are some other tumors with SSTR expression which can be considered for treatment with PRRT at their advanced stages. This is one such example of skull-base phosphaturic mesenchymal tumor causing osteomalacia, which was considered for PRRT at its third recurrence at the skull base, following 2 failed surgeries. And the patient showed an excellent response with PRRT of 2 cycles with reduction of tumor marker, which is FGF23 in this case, and substantial improvement in symptoms. Thus, in summary, the somatostatin receptor targeted theranostics integrates
Okay, so again, we'll do another virtual round of applause. So I think for now, that is all the talks we have. So I personally just wanted to say a big thank you to all of the speakers that have joined us today and all of the participants. I think it's been really great to start these conversations about research, get everybody together. I hope we can carry on doing that into the future as well. I think a special shout out also needs to be given to Gayle, who I don't know how many people have realised, but I think she's now got through her 5th zebra top. So she's been changing her t-shirt throughout this meeting through each talk. So she's had a different one for each one. So I think a round of applause for effort for her as well. Well, anyone who wants to watch this back later recorded can see if they can decide which one they liked best. But I don't know if anyone else, Rachel, whether you've got anything you want to say.
Yeah, I was just going to say, you know, thank you to everyone who's attended. I think that this was really wonderful. It was very, very inspiring. We had some really, really excellent talks today. I will say, you know, the NET community is like no other. You know, we're all friends and family here, and it's great to see everyone's faces and to get to spend the day with you. So thank you all for attending, and I hope you enjoyed it.
Thank you, Rachel. So just by way of summary, thank you very much to our ambassadors. We have 9. Thank you very much to the guest speakers today. We had 5. Gayle, by the way, is our patient ambassador. So you, even though her name's spelt wrongly on the website, you can find her on there. And you can find all of our ambassadors on there as well. And a little bit about what we do and how we try to do it. So I have no donors, no sponsors. Our next meeting is our monthly NET Chatter, which is usually on the last Thursday of each month. We have some amazing guest speakers that we've had in the past, some of whom are on this call now. But our next one, which is on the 27th of May at 6 o'clock UK time, which is 1 p.m. Eastern time, is Alexandra Gangi is our guest speaker for that one. And I hope that you'll be able to attend. Most of the posting I do is on Twitter, and so I think that's where I found most of you. Do also post, we have LinkedIn, which Angiraj is a big follower of, and also we're on Facebook. So those are the 3 places that we are. Thank you very much. Have a look at our website, netcancerfoundation.com. And thank you very much for staying with us, because I think we've overrun slightly. And also a massive thank you to Rachel and Kate for running the show today. So on that note, look, people are actually pleased with the 2 of you. There you go, much better than me doing it. Okay, so thank you very much for joining us. See you on the 27th, and have a good afternoon or a good evening. Thank you.
Thank you so much, Simon. This was wonderful.
You. Been a pleasure. Thank you very much. Bye-bye. Bye.
Bye.
Thank you.
Bye,
Thank you,
everybody.
Simon,
Thank you. Bye.
sir.
Bye-bye.
Thank you for letting me in also. Thank you very much.
Thank you. Bye-bye.